Can I also invite Dr. Rajiv Kaushal, Dr. Jayant, Dr. Kumar Prabhash, Dr. Maitri Basu, Dr. Minit Shah, Dr. Prateek, Dr. Chakor Vora, Dr. Anup Toshniwal, Dr. Sunil, and Dr. Anuradha. Okay, please come. I called him. Oh, Kumar sir को इज्जत से जाना पड़ता है ना, वरना आते नहीं हैं. I have to call Dr. Kumar sir and all, no? Otherwise he will not come over there, no? 10 minutes. था तो 25, पर तुम 20 कर दो. 20 कर दो. Okay, I think after listening to so many hi-fi, things about that, let's come back to earth. You want to come, Dr. Aparna? आ जाओ, आ जाओ. Sure. Okay. So anytime that we talk about liquid biopsy, I mean, normally the patient's first reactions actually are like, wow. I mean, ये तुम कहाँ थे करके टाइप जो है वो इससे पहले क्यों नहीं आए? This was Ravichandra Ashwin, I guess. But mine and patient's subsequent reaction to that after the report actually comes is like, रुको जरा सबर करो. Let's just put this to test. Let us actually see whether liquid biopsy is really the stuff that is made to be. So we'll start from. Come again. Thank you. I don't know whether I take it as a compliment or not. I mean, the science is never taken as a compliment because science is where there is. Entertainment is where here is. Okay, we'll start from this side. Just a yes or no. Are you a believer in liquid biopsy? And I'll put you to test. Just a yes or no. No ifs and buts and everything. The more number of time that you are taking out of it makes me say no. Not yet. Yes, no, not yet. Fantastic, sir.
Of course, I am a strong believer.
Very strong believer.
I am a strong believer.
2:1.
Believe.
3:1.
Strong believer.
आप तो हिस्टोपैथोलॉजी करते हो. आप ये तो गलत बात है. यहाँ पे डॉक्टर मेहता बैठे हुए हैं तो आप बिलीवर हो गए हो वहाँ करके. Okay, 4:1 believer, 5:1, 6:1 believer. Okay, I am not yet actually. I'm actually not yet over there. Okay.
आप फोन नहीं करोगे ना इसलिए मैंने.
Okay, उसके लिए. Okay, so let me just ask from this side, Dr. Aparna. Do you think liquid biopsy is a main actor? Oh, by the way, this is a not a Hindi movie, Kannada movie, which is called Bahubali, or Telugu movie. It's a Bollywood. This happens in Hindi and Kannada. This doesn't happen in English. So tell the Angrez people, no? Okay. Or you think this is like Katappa, who is going to actually kill tissue biopsy on a supporting role. So what do you think liquid biopsy's main role is going to be? It can be both. Fantastic. Dr. Prateek?
It's more of supporting role.
More of a supporting role as yet. Dr. Sunil? Complementary. Fantastic. Dr. Kumar?
Yeah, complement.
So I think everybody saw the slides. This is going to be the winning combo. I think the tissue and liquid biopsy is going to be the combo which is really going to make a difference. So just a basic things about liquid biopsy. This is a slide which I got from last time ESMO, which basically says liquid biopsy is like fishing and not fishing for Goa where Dr. Sahu is going. Already gone, already reached home, landed. So catching a fish is when there is a fish in the sea. But if you don't catch a fish in the sea, that doesn't mean that there is no fish in the sea. Correct? So just because you are not able to get anything in liquid biopsy does not mean the mutation is not there. Fair statement? Fantastic. When there are more fishes over there, you are more likely to catch something. Fair statement? However, you can use a single gene testing. You can use a PCR or a ddPCR or a RT-PCR, a single rod, but you can do an NGS. So just a basic, I mean, this is, for this audience, this is very basic, but for me, this took a lot of time. I said, wow, maza aa gaya dekh ke here. So these are basic rules that we actually have. So what does the liquid biopsy actually analyze? We'll start from you. So for you, does it analyze, there's so many things. It can analyze the CTC, it can analyze the ctDNA, cfDNA, proteins, TAAs, microRNA, metabolites, DNA methylation, or ctDNA. What do you think it actually does analyze and what it should analyze?
So they can analyze almost everything.
Correct.
Mentioned.
In the clinical use, what is being analyzed?
So what we need is the mutations, the particular the DNA and RNA, the mutations is what we actually, or genetic alterations is what we are interested in as clinicians.
Okay, so Dr. Kumar, I'll come to this to you directly. So, I mean, as far as I am concerned, this is my way of this, not my problem, Sanugi. I mean, as long as you give it from a CTC or a ctDNA or a exosome or whatever TEP, it is not my problems, So this is the clinician's guide to a success. As long as you give us the mutational load, whether it is cfDNA, ctDNA, but from you and then from the lab people, what is it that actually will give us the right, answer for that?
So at this moment it is ctDNA,
Okay.
But looks like you will get whole lot of information near future, because now, for example, people are not only able to get a cell out of A and able to sequence. Now this issue will come up that think about tissue was negative, ctDNA positive, we are treating today. We thought this around 10 years back, we were thinking liquid biopsy, you will always miss.
Correct.
We started looking, you may pick. Now think about liquid biopsy negative, tissue negative. And you did single cell, it is positive.
Yes.
So, as on date, we are not there, but yes, kind of technology we are getting now. You will see soon many things coming there.
So
maybe we can follow Jayant and Gauhar.
Okay. So fantastic. So as a clinician, I mean, should we actually be looking at what is the source of that? Is it a cfDNA or a CTC or TEPs or whatever, or we just as I wrote over here, Sanugi, as long as you get some del 19 positive wherever it comes from, it's okay.
See, there's I'll tell you an issue there. No, we should look, because you have a stake there, because ultimate patient will be catching you.
Patient will always catch us, sir. Patient will always गर्दन हमारी पकड़ी जाएगी.
So, idea is that technology. Now, someone gives a report.
You need to know the report.
So, how confident you are with the person that he has gone through that technology part? Because that technology is not easy. But in case someone is very good in it and he or she gives it, today I don't do it routinely.
But you might just.
But I'll say, hey, if I get ALK positive third line, think about, or EGFR positive third line where everything has failed. Someone says, Ajay, single cell, I saw it. Will I use it? I may end up using it. But today's, I'm not saying please do single cell. No, that's not the message I'm giving. Today it is ctDNA. But watch out. In you will see next few years, you will see whole lot of data coming from this.
Fantastic. So now let us talk about, this is what I asked Dr. Anuradha at a message at 10 o'clock in the night 2 days back when I was actually trying to prepare for this. I said, madam, आप चाहते क्या हो मुझसे पूछना? You've written CTC, cfDNA and biomarkers in lung cancer. I had no dash idea about what exactly are we going to do with. So when in doubt, confuse more people. So let me talk to Dr. Aparna. Dr. Aparna, do you agree with this? CTCs versus cfDNA, one is the bride and one is the bridesmaid. Do you think CTCs are always relegated to there and cfDNA has taken the show?
Everyone's part of the bridal party for sure.
Yeah, but the bride is different, right?
Yeah, but I do think circulating tumor cell. So we have to actually understand what is circulating tumor cell.
Yes, that's what I want to understand.
Okay, so
that is why I made fancy diagrams like this so that you don't ask me all these questions,
So it's. I'm confused. 1 second.
I know.
CTCs,
when you can't convince them, confuse them.
So a single cell, a single cancer cell, right, which gets from the tumor site when a single intact cell gets lysed, that is your circulating tumor cell.
Okay.
cfDNA is cell-free DNA, is essentially from the blood sample. When you take a blood sample from a patient, there are different components to it. So in that you will have the patient's DNA, which is a germline component. You will have the chip mutations in it. You will also have your circulating tumor DNA, which is essentially from the tumor site, the somatic DNA that gets lysed into the blood. So the cell-free DNA has a component of all of this, and it's how you extract it is what you're looking at.
So what is the problem with CTCs in Dr. Pratik? What is the problem with CTCs? I mean, why Dr. Kumar said, CTCs, cfDNA is there as yet and CTC is not really there. Why is it that so?
So there are several technical limitations. One of the prominent ones which we can cite and what we understand as of today is that lung cancer is tightly regulated. It's not very easily accessible for cells as well as cell-free DNA to enter into the bloodstream. So what we are looking at is a large proportion of the patients which will be lacking these biomarkers, and whether that will be allowing us to generate enough of the clinically actionable outcome. So that's a big question. But wherever it's present, there it will be reliable.
Okay. Anybody else? Dr. Kumar? Dr. Sunil, yes, first.
So basically, it's a sensitivity that is compromised in the CTC. The sensitivity is quite low.
Okay. Kumar?
One of the things we forget, if you take NCCN few years back, before they ever recommended ctDNA,
There was CTCs.
CTC was
CTCs
there.
everywhere was there.
In a
Then
lung,
colon,
in
breast,
prostate.
everywhere there was there.
I tell you, there is a good conversation, and
Yes.
we did have it, and we had for years. So when this CTC came, and Jayant had a keen interest on CTC. Somehow, I don't know, whenever I saw the data, it was already in guideline, and then he used to come, देखो ये guideline में है, and he was developing the technology. ये तो technology मुश्किल है. I thought, पता नहीं, he will be able to develop or not. It's a different matter that he only developed it, he got regulatory approval. But I was always skeptical कि CTC, the way it looks like 1 cell, 2 cell, 3 cell, if you miss 2 of them, it is gone.
Correct.
But somehow, CTC faded away. So I used to tease him.
That's what Dr. Jain, that is exactly what I want to know is, problem क्या है CTC में? I mean, why is it?
Story खत्म नहीं करनी चाहिए. इसलिए खत्म नहीं करनी चाहिए.
10 ही मिनट है सर, बाकी स्टोरी भी सुननी है अभी. So let me go to Dr. Jain.
So,
Yes.
उसके बाद then I should tease him. कि देखो, I kept telling you, this is not useful, and you kept working on it. I kept saying that work on ctDNA. So finally he conceded. Now it's the other way around. Now when the CTC data for sequencing starts coming,
Yes.
now it is totally different ball game. Then you realize that hey, he was smarter.
Was smart. Fantastic. I mean, we are dumb by in that. At least I am dumb. This much I can realize after learning to CTC and ctDNA. Yes.
Everything is written in blood.
Correct.
What goes around comes around. So I think they have different roles. I would disagree to this panel that CTC has its own different role because it's going to cause a next level of a disease which we ignore often. So diagnostication is important from the ctDNA, that is well established. If you have to monitor, which is most important as facet of treatment longitudinally, CTC's presence actually shows that the progression is there in spite of no.
So can I just ask you a very simple question? Let us say if I have to diagnose a patient, ctDNA is good enough.
Yes.
But for monitoring the patient, we have got a lot of ctDNA studies
CTC.
also. That is not good enough. CTC is better. Is that right, Dr.
Yes,
Jain?
you said it.
Okay, but that is not something which I read. Actually, Kumar, will you agree with that statement? But you said just, they can do the spatial transcriptomics, single cell sequencing on that CTC.
Yes,
Won't
CTC.
that be better?
So yes, see, spatial will be better on CTC as
On
compared to your
CTCs,
ctDNA.
yes.
So trust him, Jayant. I assure. More I have interacted with him, I have realized that he futuristically. So I don't say today ctDNA, but futuristically, 5 years down the line, you will have a whole lot of things related to CTC, which will be there in used in multiple ways.
Yes.
So monitoring.
So I think for monitoring the ctDNA is better. The reason being it
Also
has
very easy, no? I mean, there are a lot of papers. I mean, that is what I was just. There are a lot of papers which I can show you also. Which have
considering
been,
it's-
why is CTC better? That's what I want to know.
It's a twofold. I mean, ctDNA definitely is a monitoring tool if you look at a Cohen et al. That published. Okay, but I think the main cause of a metastasis seeding is going to happen from the CTCs. So
Okay.
presence of CTC is going to extend the disease. Absence of ctDNA, that means, yes, the patient is in the remission. Presence of a CTC.
For the MRD by and large, that's what you're
Yes,
saying.
it's a cellular disease which is going to cause an extravasation. It is going to cause an invasion.
Okay.
I think there is a terminology difference,
Okay,
oncology.
Dr. Gauhar, what is it?
True positives are more reliable,
Okay.
but the false negatives, that will be a bit of a challenge.
because the ctDNA has a shorter half-life in the blood, so that has a more reliability.
Okay, Dr. Gauhar, you have a point?
So, see, why CTC is better than ctDNA? Though as one Kapil said, it's not yet. ctDNA is coming from dying cells.
Okay.
We know cells are dying and they are not important for monitoring purposes. Whereas CTCs, these are live bombs, and they are going into the circulation. And more importantly, now when we do downstream molecular analysis on the CTCs, like PD-L1, R2, and many more surface markers. Example PD-L1, not it's not as we do on tissue for immunotherapy, but PD-L1 on the CTC gives them license to escape the immune system, they go into circulation and they go into the different parts of the body and metastasis. And second thing is when we talk about ctDNA, we have a lot of issues like chip mutation. So when you do the CTC based DNA,
The chip will be out.
so you can eliminate easily
The chips, yes.
and you can eliminate a lot of noise which
Okay.
comes through the aging process and all that.
But one more point which I read was regarding the detection and enrichment of CTCs. The technology to isolate CTCs and enrich them is slightly difficult. Has that been taken care of, Dr. Chel?
Yes, I think, we are talking of an old wine when there is a new bottle actually coming. I think that is what damage that SWOG study has done it. We are talking about enumeration number. No, one single CTC with PD-L1 marker can deactivate T cells against it. It is proven now, and as Dr. Kumar
So
said,
at present, ctDNA is okay for diagnosis and detection. CTCs may be used for follow-up. The presence of CTC will be there more for MRD. ctDNA can be used for prognostication. Is that okay?
Yeah.
Fantastic. Now let us get to know the basics. Don't mind, but there are a lot of molecular people over here and everything is over here. The status of companies which offer liquid biopsy is like this. And everybody says, I am the best, sir, हमारा 74 जीन है, हमारा 75 जीन है, हमारा 200 जीन है, हम 3 दिन में देंगे, हम 2 दिन में देंगे करके. So I have trust issues. I have a lot of severe trust issues. And I think all the clinicians have. So I have written over here because I knew Dr. Mehta will be here. So I wrote what all should a poor oncologist like us, naive oncologist like us, look in a proper, ma'am, you haven't spoken till now. In a liquid biopsy report, can you give me a kunji? That is how I passed my pathology and microbiology, to look for what exactly is supposed to be looked in a liquid biopsy report. वो तुम्हारा कुछ नहीं हो सकता, आप यही बोलोगे ना, तुमसे ना हो पाएगा.
What I know from at least from the theoretical knowledge, because in our lab we have not yet started the liquid biopsy things.
Great, ma'am. Thank you.
We are only working on the solid tumor. But yes, some basic parameters are very important in the liquid biopsy reports, like the depth of the sequencing depth. That is very important. And this multiple times what is discussed, the chip mutation, what is coming or not, whether it is there or not. These two is very important. And if it is CTC, then number of CTC per ml of plasma, that is very important, what I know. Yes.
Let me go to Dr. Kumar. Kumar, from a clinician's point of view, just some 5 basic points that we should say, when we look at the liquid biopsy report, and how do we trust that report?
See, at this moment, I totally agree with this. Is one of the challenge. So what I do is I ask every lab today also that, hey, show me some few hundred patients data you have done in tissue and blood. That's the first step.
So one thing is concordance.
Concordance, and especially for fusion.
Okay.
Because see, in the you bring ctDNA based testing, so it is DNA based. And DNA based, and
miss fusions.
In fusion, which is okay. And I need to concede that I have been shown more than once that DNA based you can do as good as you do with RNA based. It's not like you will not, but then also, and then it should be fusion, and then some of the fusion is a tricky one. Like for example, NTRK. So it's a tricky one. So
one is you want to see the raw data comparison concordance study.
raw भी नहीं, आप बोलो आपने किया है, आप हमें दिखा दो कि ALK आपने 10 पेशेंट में टिश्यू में किया, 10 पेशेंट में ब्लड में किया, what was there? If someone shows me all 10 I picked up in tissue and blood,
so all 10 तो सर संजय पोपट की स्टडी में भी नहीं हुआ था.
I agree with you. So someone shows me 8 or 7, you are comfortable.
So now you are telling 7 on 10 is good, 10 on 10 is bad.
10 on 10 is...
They all are listening, no? They'll show you 7 on 10 then.
I agree with you.
We are smart people, sir. We will know अगली बार साथ ही दिखाना है. I heard 2 things today. One is to say sorry, you will be okay. So 7 on 10, you will be okay. So 7 on 10. No, sir. I'm being honest with you. The people will not show this data.
That's what. Now, good thing is that multiple discussion. Now it has happened that there are labs saying, hey, we have done it. We say, hey, please show it.
Okay, fine. They have shown, sir. 7 on 10 is there. Then the report comes. Then what happens? Then what all should we look for?
So that's the first step. Next step is, what you do in any way other molecular testing. Hope they don't change the way of doing it, because sure, as she was saying, now what were the quantity of DNA being put? It will be lesser than what you have.
Should they be reporting? I don't know how much DNA was extracted, how much nanogram of DNA.
Absolutely.
And are we all doing it?
No, it is not being done. But
so why is it not being done?
So that is because no, you are not asking. The
I am asking,
Amitabh
sir.
Bachchan is not asking.
I
तो
am
अभी कहाँ
asking,
से
sir.
बाकी लोग सुनेंगे? हम लोग हम उसको बस के टांग तो खींचने दो उसके अभी इतनी देर से मेरी टांग खींच रहा है वो भी. So I agree. So there are labs where, so example, you get 20-page report. You say, hey, एक page में let us have these quality parameters which meeting. What is the depth? What much? In fact, you can ask what percentage of the sequencing data you have not used in analysis, because there are almost 25-30% of the data. There are people there, far smarter. Jayant, sir is there, Om Shri. You don't analyze. You have 20,000x. Think about, they say 1,000x. It is not 1,000x. It's ultimately 700x. Am I correct?
I have a
So those
request.
details, it is good to have that nuance in a one page, and one page will be good enough. So rather than 20-page report, one-page report, drugs.
We will see for the
Last
drugs.
can handle better than any
We
of
are
them.
not bothered about the drugs, but it's a request from us to everyone, because sometimes we get, see, everybody will come and say, 100 WhatsApp messages will come, sir, we are the best, and finally when you look at the report, there's nothing in the report. So I think there needs to be a standardization among the labs, and you guys will do a much better job than we don't know anything. We are just asking a simple question. So
हमारे लिए आसान है. We call Om Shri ना तो.
we call Dr. Mehta, no, हमारे लिए भी आसान है, but there are people everything around over there. That's the problem. So not everybody has an institute backup. So we need to have
Then we have molecular tumor board. Then we have.
Okay, so just a last some question over here. I'll go to you. Let us say you have when do you send a liquid biopsy? At diagnosis, let's say a non-smoker female comes to you. A non-smoker female comes to you. Your tissue biopsy report is showing no actionable mutation. Do you send liquid biopsy upfront, or you send after that, or you are happy with the tissue NGS and you don't send a liquid biopsy?
So if I have good tissue biopsy sample and this thing, then I don't send the liquid.
You don't send
I
the
do not.
report. Anybody else who will want to send a complete on the science? Forget the money of that. I mean, Dr. Amit, what will your take on that be?
I think
Complementary will be something which is there. Okay, so this is what the Sanjay Popat study which I was talking about. This study actually did a concordance between a tissue and a liquid biopsy, and what they basically found out was that liquid actually missed less. Tissue actually missed more, and if you do both tissue and liquid, 33% more samples were detected by adding both. Timing of the test, because timing is everything. A complementary approach is something which is very important, but how many people are able to do? Very few people are able to do, and that is predominantly because of the cost issues. I mean, you should be loading in dollars to actually get that approach from here. So even the NCCN guidelines basically recommend that you can send both. It actually says that hum saath saath hain, but that's an old movie. It doesn't really work in today's this thing. Let's say you get a MET exon 14 positive on tissue or on liquid. Tissue missed it. How confident are you to give capmatinib or tepotinib?
So I'll discuss with the molecular pathologist. And
They say they are the best. Yes, it is there, sir. And you call up the NGS paper also. They say yes, it is not there.
Then I will give it. Yes.
Then why do you want to call up? Kumar. I have to place the owner somebody's shoulder, no? Discuss with Dr. Sunil. He is very confident, still wants to give it. Okay.
So, see, we have been doing for EGFR now. But the only problem is the MET is so uncommon that we encounter. Yes, there's a challenge. So I think so, and this is where spending time with our molecular pathologists becomes important. So they will show you. So whenever I have asked people, this is negative, and then you see it, hey, it is there. Where they manually check and they say it is there. IgV. So these are words. And then
these are the words you should use over there to make yourself look good, and मुझे आता है IgV क्या होता है,
So, but that when they show it, then you know. And again I repeat, EGFR we used to doubt it when we started.
Yes,
then
but now we
learned later on that hey, EGFR you miss many of them in tissue and you pick up extra in blood and you are treating it. So yeah, go ahead.
So this was for the vision. Yes, please.
Yeah, just want to add here. I don't think it is a difference between the genes on liquid biopsy. It's the nature of the test and the way we look at the mutations, like IGV was mentioned. So it's not about EGFR is
No, I think
more
Met
confident.
just came over there because it's a rare mutation,
Rare
and
mutation,
costly
yeah.
medicine, and you missed the bus. So that is just
Exactly,
like that. And
exactly.
also because I had a slide on Met, that is why. Dr. Mehta, sir.
So the problem is that in the tissue biopsy, you are looking at a particular WAF to report.
Yes,
The laboratory has decided that it will use 5% WAF,
correct.
and if the laboratory has done the due diligence, it will show it on the RNA as well as on the DNA. So that is about the solid. In the liquid, you don't have these hurdles. In the liquid, you just say it has a fractional abundance of 0.01%.
0.01%.
And then
And leave it to the clinician to say, de do ki nahi dena hai.
So
Fair enough.
So this cuts both way. You want to have certain WAF for the solid so that you give appropriate treatment and you don't, the false call are not included. The another problem with MET exon 14 is that it has a pseudolog and a homolog, and it often aligns with PPKR1. So on a IGV browser, you will see several times the call has been made with deletions. Have you seen it? Now what do you do with it? It is a very difficult call to make when you have that kind of a IGV appearance. So don't put them.
So what do we?
Don't put them in that comfort zone that you will see the browser and make them.
No, but sir, then what do we do?
So here there is a true challenge. The challenge is that you shall use an RNA and a DNA both, and you should show complementary alteration in both.
In both them.
Until that happens, you wait.
Sir, in the IGV, I was not saying that let's put it the blended way. The idea was that if you have an indel realignment program running in the pipeline, which will take care of this misalignment.
It is still calls.
No, sir. With the indel realignment, we get rid of.
So the call has been made after appropriate penalties have been made. So it has made penalty for a deletion, 2 deletion, 3 deletion for 1 SNV, and it is still made the call. You see usually, okay, there is a deletion, we do a single gene confirmation on solid tumor. So I have
No.
this 94 to 35, base pair deletion is there, it comes as a 94. If deletion is not there, we do that, you have to do.
I think you will have to do a lot of due diligence and further everything.
I have some.
Let's hear them out. Let's good.
Okay.
You don't take lightly Metaxone.
No, I completely agree with you, sir. The only idea is that.
Think about we are clinicians so that we
Yes,
understand.
हाँ, we understand.
Very good discussion.
हाँ, we need to understand more. मेरे का क्या था, मेरे को तो डॉक्टर नराता को बोलना, you are the organizer, मैं तो बैठा हूँ यहाँ पे. मेरा काम तो आग लगाने का था, मैंने लगा दी सर. People will remember this discussion. मुझे क्या हो गया, मेरा काम हो गया सर. You have earned your value for entertainment. I have got this. I have no issues.
So basically,
Yes, Dr. Kumar.
what? Just a minute.
So I think, there are 2-3 points. One is when we talk about, when we do the validation, say 5% of WAF, I saw it. Let's imagine I got a WAF of 4.5%. Should I discard it? See,
No,
this is-
I think what Anurag sir said is it's about misalignment. It's about misalignment because of the pseudogenes.
First, when we talk about the WAF, you have the cutoff.
Yes.
And sometimes it comes below cutoff.
That we have
Few
agreed.
We agree with that. That they will write in the report also that the WAF is less than 4.5%, and they'll inform the clinician. That happens all the time. That's okay. Tell them about the liquid biopsy. वो tissue NGS हमें आता है. हमें liquid नहीं आता. हमें वो पढ़ाओ.
Canonical alteration, you should report with a note that I am reporting despite by WAF.
Correct.
of 5.
That is okay, sir. Sir, tissue हो गया, sir.
You won't do it for a hypothetical alteration that has not been reported.
Sir, correct, sir. वो हो गया, sir. Sir, liquid
Mehta sir,
Sir, liquid
WAF
पढ़ना
we
है.
agree.
हाँ.
Now coming to
Liquid
this,
पढ़ना है, sir.
specifically exon 14, which we talked about. I know it was very nice discussion, all three. So we heard Dr. Mehta. Maybe you want to say first, or yeah, you can go. So what? For example, tissue is negative, blood is positive. So let me put it for clinician. When we think it is false positive,
Yes.
is it possible?
So yeah, so there is a possibility you get a false positive, which is
How? For us to
Yeah,
understand.
yes. It could be,
हमारे समझने के लिए वो
it
है.
could be like 0.1% or even 1%. We know that there is a limit of detection, there is a sensitivity of every assay. But when, say for example, if I had to do it, I found exon 14 mutation on DNA in liquid. I'm not talking about RNA. So RNA is later part we talk about because there are a lot of issues. So DNA. So now what is important is when you have designed the assay, and if assay has been designed and you have captured those regions, splice regions, the probes are very well put there, and the tiling of the probes is very important. So in simple languages, I use this. If there is one terrorist in the room and we send one army man to capture or kill that, there's a 50% of chances we capture and kill. Now if I send 2, the probability of capturing or killing them is increases. If I send 10, I increase it 10-fold. So that becomes very important when it comes to the designing of the assay. So if assay has been designed in that way, and then you capture it, the probability of this capturing exon 14 mutation on DNA is very high. And when it comes canonical, non-canonical annotations, so what is happening often, when we do the analysis, it is very important, when we do the analysis. First we do the alignment of the reference genome, and then we do realignment. So why the realignment is needed is to avoid, if there is an insertion deletion, indels, because they are tricky. You realign to make sure that, you have aligned your reads appropriately to the actual, reference genome, so that you avoid that false positives. If I have not done realignment, any structural variant, including splice variant, translocations, fusions, copy number are not accurate. So I believe most of the bioinformations will be doing that. That's the important step. You do the realignment. Now some people use online tool, just upload something, and we don't know what is there. So now if I have a tool, I just upload something. What has been in the background, we don't know that, and then there's a higher probability of I miss it, and it is a false negative.
So if the realignment is there and if you see it, you say it's positive, then for it is not false positive, it's true positive. Am I right?
In addition to that, yes. In addition to that, there are multiple parameters like quality, base quality.
Dr. Kumar, I think we need to. Okay.
Last
30 seconds.
Last for Pratik.
Last 30 seconds for Dr. Pratik.
I agree with his explanation of indel realignment. To further transfer it to more easy language. In the first pass of alignment, we use a fast algorithm, which is little bit less accurate. In the realignment, we use a secondary algorithm, which is very accurate. And that we are doing only in the region of mutation. And that is allowing us to improve the accuracy. If those 2 checks are there, then I would say a true positive call is a reliable.
So just in case none of you also understood a millimeter of what they were talking about, you're not alone. I was also there along with you. I mean, something I read about IJV and misalignment and realignment, वो मैं जाके पढ़ लूँगा रात को जाके. And then Mrithi, but thank you all the. Okay.
Most of the points that I wanted to say has been said. It's just that I want to re-emphasize that the padding, intron padding and the panel design is the most important thing when we look at the any liquid biopsy assay, because the padding and tiling, what Dr. Gohar told, that it is very important, and then the quality.
Sir, आज के लिए इतना नहीं हो पाएगा सर वहाँ पे ना. So that is okay.
And the sequencing depth.
So thank you. I think thank you. I mean, I could not have asked for a better this thing. Thank you.
Thank you for a wonderful panel discussion. Yeah, thank you, Tanurada.
Thank you, Dr. Ahmed, and for chairing this session. And, I think we quickly move on to the last session, panel discussion. May I invite Dr. Vanita as a chairperson over here, I think, and moderator is Dr. Trupti Pai.
बंद है हाँ नहीं शी इज नॉट देयर तुम्हीच या मॅडम Thank you. To complete this brilliant molecular workshop, I invite Dr. Trupti Pai, Professor of Molecular Pathology. That's correct to say? Molecular pathologist at Tata Memorial. Dr. Trupti.
Thank you. कोणाला बोलू? ठीक है. Okay, so very good evening to all. After the most controversial topic of ctDNA, CTCs and most entertaining panel, this will be a little boring one. But again, my point is to highlight issues which we encounter regarding fusion analysis. So today we have best of the panelists. So I would like to invite Dr. Chakor Vora. He's not there. Okay, Dr. Akhil Kapoor, Dr. Amit, please. Dr. Omshri Shetty, Dr. Suruchi Agarwal, Dr. Kunal Sharma, Dr. Anurag Mehta, Dr. Anuradha Madam, Dr. Moinika, and Dr. Pratik. So maybe okay, so the clinicians' issues and challenges I think we have already covered, but still I would like to ask the medical oncologist here, like regarding this interpretation of NGS reports, what are the usual scenarios that difficulties you have, common difficulties?
One important problem, common problem is that report itself is not complete because it doesn't have many of the parameters which we want to look at. For example, depth of coverage. So sometimes the reports are inadequate, especially when the reports are not being discussed with the clinician. So that is a very common problem. But since we have most of the time in-house reportings, that is not so much with us.
So regarding reading on your own,
yeah.
There will be. What about you?
So important things are the tissue content initially. So most reports they misses. Sometimes the mutations they are multiple. And which is significant, the VAF really is one of the things. So even with less, it is being written at the top, and whether it is a real driver mutation or just a passenger mutation, it has nothing to do. So we don't get that idea. Sometimes we see that TP53 more than 50%. Few mutations are which are not a driver but still having a very high VAF. So all these things obviously we go with a molecular tumor board, then rediscuss and then come back. But there are many mutations which comes, which have no role.
So with more and more comprehensive or broad-based, we have this issue of multiple variants and where there is a difficulty in interpretation. You want to add something?
We have a problem with variants of unknown significance in all weird genes which are reported, and we don't know what kind of an interaction they have with the driver. So that is one area where I find it very difficult to understand.
Yeah. Again, with the broad genes which are recently started, we will have a lot of data but not literature much on it. So this is the usual scenario that we have. I will just skip 3. I will just directly go on to this case 1. This is a 57-year-old male, no family history of cancer, smoker, and with complaints of cough since 1 month, breathlessness. And CT scan, there is a lung lesion which is encasing vessels and all. There are mediastinal lymph nodes. Biopsy is there. So Dr. Kunal, with this histomorphology and this content, are you do you want any further test, or you will directly run NGS, or you will not?
No, I think this looks like a poorly differentiated carcinoma. I can't really see a high power view whether there is any keratinization here. Now it looks like there is some keratinization. Maybe we can just do a P40, a single IHC marker would suffice and get our diagnosis in place, and then probably subject it to further molecular testing. Okay.
So as we, I showed you this course. So sometimes there are multiple cores, but tumor is very scanty. So pay weightage to the histology. Like in this case, there is a very typical keratinization. So it's okay even if you don't do the IHC, you can directly write that there is keratinization, and you can call squamous and then leave it to the molecular. Now, in a case of squamous with a 57,
I would just like to say the only reason why maybe an IHC might help, because you might find both components, and driver mutations for an adeno component are different, and the way we treat squamous.
yes, that is a very good point. So look at the histology. When you feel there is suspicious for adeno component, then you run. If throughout there is the same morphology with squamous, there is no need to run IHC. So with this, there is a squamous carcinoma, and so every case, means across the ages in squamous, will you ask for molecular? So elderly patient also. So again, a point to be noted that even a squamous carcinoma across all ages, we go for upfront NGS. So this was a little older case. The EGFR was done, which was negative, and PDL1 was 20%. So would you like to go for NGS? So in current scenario, yes, NGS was done in this case. And this is what is the report. Okay, so now looking at ALK, are you happy like you have got alteration in ALK? Yes, so I will come to you. I will just ask what is there, Dr. Moinika. Are you happy to have this report? So this is a very lung specific panel, 50 gene panel, and you have no other alteration, you have ALK imbalance.
I would like to know the translocation.
No, this is the report. There is no fusion, anything. You have got the report of ALK imbalance.
Then I'm not very sure what to do with this report then.
Okay, so you will approach the molecular tumor. So
Yes.
Dr. Anurag, sir?
So we have had some cases like this where there was an imbalance, 5', 3' imbalance was there. So this is a supporting marker of a fusion rearrangement, because as the translocation happens, one part will be transcribed less, the other part will be transcribed more, so this imbalance will happen. So in this case, unfortunately, you are not getting, maybe you have not run the RNA sequencing together, or you are relying
So
upon
this is DNA, RNA,
combined.
NGS done both,
Okay.
and this is the final
So
report.
it happens sometime. I think you need to go for an IHC or a FISH rearrangement, some orthogonal confirmation that ALK rearrangement has happened. Obviously, you will not know what is the partner, but that shall not matter.
Dr. Om Shri, ask, please.
So if this ALK imbalance ka matlab hai, ALK fusion has happened and therefore there's an imbalance. So why they can't just write ALK fusion? I mean, this is totally just to confuse us.
Yeah.
No, they have not seen it. But it is also a supporting element for a fusion rearrangement. So when you are seeing a fusion rearrangement, there's certain values, it must cross that value, or it should be below that value. Then your call of a fusion rearrangement is more concrete, more solid. It's a supporting element. But in this case, you don't have the ALK call, so do a FISH or do a IHC, and possibly they will come past it.
Okay, Dr. Suruchi, and then Dr. Om Shri.
So basically, there are different methods of doing ALK fusions. So this is one of the method, actually. I think they have done RNA, but they have done a PCR-based method where they are looking at the exonic expressions. So exonic expression of the 3' end of ALK will be lower as compared to the 5' end of the ALK if the fusion has happened. So this is probably this method. That is why they are not able to report the partner. When you do NGS-based RNA sequencing, you will get the partner as well as, and when it is DNA and RNA based both, you will even get to know ALK imbalance, actually adding the confidence to the fusion that you have detected through RNA based sequencing. So whenever we are ordering the test, we should know the method what they are using. So ALK imbalance is obviously confusing whether we should take it as a positive or not. However, it is expression based. It shows that the half of the ALK is expressing more, which may or may not contain kinase domain. That also we have to know. So RNA based NGS sequencing to detect the fusions will give you many more information, like whether it is in-frame fusion, whether it retains the kinase domain.
Sorry to interrupt. So, but this is RNA-based NGS also. I mean, they have done DNA and RNA sequencing, NGS, and they have not found any fusion partners. And this is the report after doing RNA-based
That is very unusual. It could be some out of frame or uncharacterized rearrangement that they have reported as alk imbalance.
Dr. Omshri, so we have
So
this panel
RNA based will give us definitely a partner retention of kinase domain or not, partial domain or full domain, plus
Not
in frame
always.
out frame.
Not always actually.
No, I mean whether it is there or not, at least we will get that.
So Dr. Omshri Shetty, we also have this panel. So this is some outside report, but we do encounter this, and this is this OPA panel.
Sorry. So yeah, I mean, we see this trend even in the NGS panel, which is amplicon-based library preparation. So you do see, I mean, but then it is NGS which is spanning the...
It is amplicon based, so if it is hybrid capture, then it will be much, it will,
No,
so
yeah,
I was
agree.
talking about hybrid capture.
Agree to your point. Hybrid capture will be more specific. It has its own pros and cons, but amplicon-based library preparation on NGS spanning the breakpoint regions with having several 5' 3' regions crossing across the tyrosine kinase domain, you still see these things. And usually in transcriptomics, when you have a whole transcriptome, RNA transcriptome, this algorithm is extremely useful because you can go back and look into the entire data. But when in an NGS, in a limited panel like OPA, you do get these things. So as rightly mentioned, it's always good to go back and do an orthogonal testing. And we have seen several instances where alk imbalance was there and we didn't get it.
Yeah, if we do RNA based hybrid capture, we will not have to do any confirmation.
Yes, I will come to that library. So point is that sometimes you have such cases where you don't have any fixed answers. Coming to this panel, so you do have right side partner and left side partner because this is amplicon, but this strategy is in OPA, which is like a exon tiling, again a different type of PCR, which in the which will help us detect novel fusion partners. So here it means that you don't have a typical partners that are present in the panel, but you might have a novel fusion partner. So that is what is this panel, and
I disagree here a little bit on the RNA sequencing based NGS detection. If you include the exons of all oncogenes, I mean all exons of an oncogene, you will be able to pick up known unknown partners.
so this is so this is a amplicon base. This is not a hybrid capture.
No, exactly. So amplicon can pick up known unknown partners based on the expression of exons in the ALK, right?
It can.
Yeah.
There is an indirect observation of ALK fusion.
Yes.
Exons
Yes.
are supposed to be all equally expressed, but some of the exons are highly expressed and other exons are lowly expressed. That is an indirect indicator of a fusion happening. So this is indirect report.
Yes,
but that
exactly.
is what we discussed, it's a surrogate evidence.
It is a surrogate evidence. Yeah. Okay. Orthogonal testing was done and IHC is negative. Let me now put across this. IHC is negative here, adding to further confusion. So we do encounter such cases. The point of including this expression analysis is in general to identify novel partners, whereas Dr. Pratik rightly said, it is an indirect evidence. Now question to the medical oncologist, are you ready to give, now there is no other alteration, no other driver thing, are you ready to base your treatment based on this report?
Definitely not. Just tell me, was IHC also negative?
Yes, IHC is also negative.
Fish was also negative?
Yes.
Then we'll take it as negative only.
Yes. So sometimes we think NGS is the final answer, but then again some cases we have to go back and switch over to some orthogonal testing, and this is one such examples where lot of discussion kept on happening because whether to consider this or not. So coming to this, so challenges and solutions. So that is what I wanted to tell. What is the, so Dr. Anuradha, challenges in fusion detection?
Yeah. When you're doing actually the RNA fusion, or if you want to look more of fusions, I think we should go with the hybrid capture method. That's the best part to do it. And in the fusion detection, like in the liquid biopsy, there can be challenges in the fusion detection, not in the tissue biopsy. That's what.
Anurag sir? Okay, you can come to hybrid capture versus amplicon based for the audience.
So I mean, obviously hybrid capture requires higher input of DNA.
Yes.
Because you have to pick out that
Yes.
particular, you have to, bait it. So you need more amount of DNA. The amplicon based require less amount of DNA. And if you have actually made the primers pretty well, you've designed them well, because one of the partner is always constant breakpoint, the other partner has variable breakpoint. So if you have designed properly, I think you should not miss them on an amplicon also. But theoretically, probably hybrid capture is a better one.
Coming to the real world life scenario, how many, so Dr. Suruchi, you were saying hybrid capture. We all know hybrid capture is very good in terms of sensitivity. So, but when it comes to RNA, how frequently does all these NGS libraries are based on RNA, I mean, based on hybrid capture? How frequently, like maximum labs if you see, RNA is amplicon based, DNA is maximum time hybrid capture, but because RNA have little poor quality, amplicon works better. So, which panel do you use?
We use hybrid. We have all of our panels on hybrid capture.
So all fusions also
all
hybrid
fusions.
capture.
So what we do is we include the exonic regions. So among RNA and DNA, so we include the exonic regions of all the genes that we want to use in our panel, and it can identify known as well as unknown partners, because if the probe is binding to, say for example, ALK exon 6, just an example, and it is, the breakpoint is at gene A, which is even not in the panel, the half of the read will align to ALK and half of the read will go and align to that gene A, and unknown partners will be picked up. We have picked up a lot of unknown partners, rare partners with ALK as well, and we have seen the response as well. Coming on to the liquid biopsy.
No, I will come to that.
Okay.
So with hybrid capture, you pick up unknown partner, but just that the quality of nucleic acid needed is little higher. So in diagnostic settings where you have more of referral, quality is poor, tumor tissue is less, more practical is amplicon. But you have to keep in mind that you might miss on certain unknown fusion partners.
And also it will give more information, as I was mentioning, about the domain, retention of domain, and in-frame and out-frame kind of information also will be given by hybrid capture, because entire transcript is known.
Okay.
Entire fused transcript.
Okay, we have just 4 minutes. I have little important points to make. Next discussion is on DNA-based fusion and RNA-based fusion. Just two points. Like, sir, our DNA-based fusion, how comfortable you are using? Yes.
You need mate pair sequencing. The regular sequencing will probably DNA-based fusion rearrangement. Seeing will be, you will be have lots of false negatives.
Okay. Dr. Om Shri Shetty.
I still feel like, it's better to go for RNA-based fusion rather than DNA-based. Of course, in a scenario when you have tissue is an issue, at that time, probably you can think of going for a DNA-based panel, but you would end up missing.
Yeah.
So RNA is not bad, because remember, you have thousands copies of messenger RNA versus 2 copies of DNA. So this concept that RNA yield will be less, we have seen in our practice, RNA yields are almost always better.
So it is more sensitive, DNA based. Yes, Dr. Akhil?
As a clinician.
DNA rejections as compared to RNA rejections. Yes.
Sorry?
We do send more of DNA rejections as compared to RNA rejections, and that is because of expression.
Yes. So,
Quality of the FFP
fusion report, DNA-based report, and you don't have tissue material left over. Would you still distrust it?
No, not because sometimes the intronic sequence will be too long to get covered by the PCR. What will be the largest length of a fragment that you can do PCR on a formalin fixed section?
That can be done even for several thousand kb.
No, FFP.
Generally for NGS, the insert size varies from 75 to 120.
Right, yes.
Isn't it?
True.
That's the most comfortable. And I am telling you, the MET exon 14 skipping, the single gene assay that I have prepared, the 235 fusion, which is without skipping, rarely you see. You only see the 94, but you are happy seeing the 94 because that means the fusion rearrangement has happened.
So there are 2 important points when we look at DNA-based fusion. One is the technicality, the probe design, and the other one is interpretation. So when you are doing hybrid capture-based DNA, using DNA as a fusion detection tool, you have to actually include the intronic breakpoints, and if you do not include, if it is unusual breakpoint, you will definitely miss it. That is about the technicality of the probe design. About the interpretation, when you get the fusion event, always happens at DNA level, right? So fusion event has to be transcribed into a meaningful transcript, which is translating into the overexpression. So if the fusion has happened in a way that it is rendering the transcript out of frame, then obviously it will not. So even if we see any event at DNA level, it may or may not transcribe into a viable RNA transcript.
Please remember, 70 to 80% of out of frame or frame shift rearrangements lead to nonsense mediated decay.
Yes, sir.
NMD.
Exactly.
So you will not get any messenger
Yes,
RNA.
that
It
is why.
only 20% of the frame shift alteration which may actually get transcribed.
Yes.
So your reliance on RNA for the sake of a out of frame mutation is probably, sort of very far-fetched. Chasing some kind of a...
Agreed, sir, totally. So whenever you are using DNA-based panel for fusion, remember intronic regions are very large, there are repetitive sequences. Your panel designing library should include those, otherwise you will miss. So there are chances of false positive as well as false negative. With DNA-based, RNA-based are more sensitive. So fusion testing is just last, but because I think I have...
If DNA-based, you can do mate pair. In mate pair, you
Yeah.
circularize, and then the two ends come close. And then you sequence the two ends. So mate pair sequencing is the one which you can use, not the regular sequence.
Okay, so with this, because why I was stressing on this,
yes, the next session is waiting.
Okay, sorry. Okay. Just that why I was highlighting this, because the liquid biopsy cfDNA that you get, mostly you get on DNA-based fusions. So fusion testing on liquid biopsies. So what is the cutoff? Just last point on cutoffs. If anyone can add, DNA-based, what is the cutoff, and RNA-based, what is the cutoff for positive fusion?
In liquid biopsy.
So the panel I use 70 nanogram of DNA, 30,000 depth. I can go up to 0.1 and I will take 0.1.
Of what? You mean of tissue?
Fractional abundance. Because that's what the nomogram has told me. So I'm not stepping out of that nomogram.
So basically, if we are using cfDNA for fusion detection, hybrid capture method, we use UMIs. So if we see 2 to 3 reads also, and it is true in IGV, and we do report it, the fusion, if it is actionable fusion.
cfDNA fusion, honestly, we have not tried it yet. I guess probably we are going to do, but whatever I've read from the literature, I guess one read is also okay, but tumor fraction is extremely important and the abundance.
Normally we rely upon 3 molecular families. In a molecular family, those which have developed from one pair of UMIs, 10 pairs should be there, I mean 10 repeats should be there, and 3 such families should be there. That's what we use as a guideline. But irrespective, I will not give 0.01 or 0.001 because using that nomogram, there is a nomogram with particular depth, particular amount of DNA used, you can only go down to that much. Beyond that, there can be errors.
Okay. Sorry, I couldn't even complete one case. So this is how controversial RNA is. So I'm really sorry. Thank you all panelists. Thank you.